Great. Welcome back, everyone, to House Healthcare. We are moving on to Act 183 from 2022, which is the prior authorization report. And we have Department of Financial Regulation and Green Mountain Care Board here with us today to walk us through what we've done, what the report is. And again, this is, educational. It's a follow-up of things we put into place. And we also have a bill on the wall, H2, 220, I think. And that might play into this at some point in the future. So I'm going to turn it over to Sebastian and Julia.
Great. Good morning, everybody. My name is Sebastian Arduengo, and I am here for the Department of Financial Regulations, and I am joined by...
Hello. Sorry, I wasn't sure if you were waiting for me.
I was trying to cue you in.
You can introduce yourself, Julia.
Yeah, good morning. My name is Julia Bowles. I'm a health policy advisor at the Green Mountain Care Board.
Great. Thanks for joining us. And thanks for staying away because I believe you have a cold. So
I do. I'm getting over a cold, and I decided I didn't want to share it, even though I really wish I was with you in person today.
Thank you. Who's going first?
Julia is.
Okay, great.
And I'm just getting our screen share set up here. Give me one moment.
And this is on our webpage.
Got it. Looks like from the TV behind Sebastian, you can see the slides, but
yes,
you'll confirm. Great. Well, I can kick us off, and I know you have spent more time with Sebastian and with whiteboards this year, so I'll give a little more background about myself as well, briefly, before we get started. And kind of at a high level, the Green Mountain Care Board, as you know, has worked on prior authorization from a policy lens over the years. We've done multiple legislative reports, and our primary care advisory group, which is a group of primary care clinicians, has been really interested in this subject. But from a regulatory lens, we do not get this granular as it relates to kind of oversight of insurance plans. So I just wanted to kind of clarify that element. But again, it's an issue we've heard a lot about, especially from the primary care clinicians that we work with. And then additionally, at a personal level, prior to joining the board, I worked in a national nonprofit where I was working on prior authorization policy across the country. So I also bring that lens, which is sort of separate from my time now at the board.
Great.
So I will take us into the PowerPoint here. This just has an overview of what we're covering today, what is prior authorization, a history of Vermont's work on this area, and then a overview of the different parts of the report. So to dive right in, for what is prior authorization, we wanted to just start with the statutory definition. So prior authorization means the process used by a health plan to determine the medical necessity, medical appropriateness, or both of otherwise covered drugs, medical procedures, medical tests, and healthcare services. The term prior authorization includes pre-admission review, pre-treatment review, and utilization review. I'll also just add that you might hear folks refer to it as utilization management or pre-authorization, which are some other common terms. So a lot of different words floating around, all relating to authorizing access to a service or a medication in the context of a health plan. So we wanted to walk you through sort of a little more concrete and attempted simplified example of what is prior authorization. So this diagram kind of has the steps of the process as it relates to our oversimplified example. And in this example, we're taking a clinician who orders an MRI for a patient. That's the first box here. So what happens in the context of prior authorization? The patient's insurance requires a prior authorization before the MRI is covered. That's sort of setting the scene for this discussion here. From there, the clinician or their office staff submit paperwork for the authorization. So they're submitting a prior authorization form, which Sebastian will talk more about later. And they're also submitting clinical notes saying, why does my patient and their particular health condition necessitate, in this case, the MRI or whatever the medication or procedure might be. So from there, once the paperwork gets submitted, the insurance company or a third party reviews that submission and either issues an approval or a denial of that request. And if it's approved, the patient gets the MRI and all the other normal things happen from there. This is really just approving whether they have insurance coverage for that MRI. And if it's denied, there is a process by which the patient and clinician can appeal the decision to sort of further stages to say why this particular service was medically necessary and why they do think it should be covered. And we'll get into this more, but I do just want to flag sort of at the phase of submitting the paperwork that can take a lot of different forms, which is something this committee and this report have looked at. Is it faxing something? Is it an electronic form? All of that. So there's a lot that's built into each of these simple boxes on this slide, but at the highest level, this is what we're talking about when we're saying a prior authorization and we're sort of walking through the process. So next, I wanted to just go through the different perspectives on why we might want prior authorization, why it's something your committee is hearing a lot about from constituents, sort of all of those perspectives on this topic. So from the insurer perspective, health insurance companies and payers, whether that's Medicare or Medicaid, use prior authorization as a cost containment tool. And this excerpt is from DVHA's Act 140 report. It's really just here for reference, but I've bolded some terms here like managing costs, ensuring safety, upholding clinical standards, and secondary uses of prior authorization that they note related to fraud and waste. So that's sort of why we would want the prior authorization as a checkpoint for accessing care. On the flip side, the provider perspective for prior authorization, as I'm sure many of you have heard, clinicians report administrative burden associated with prior authorization. That's, I think, why there's been multiple studies and discussions about this issue and something that the board has heard a lot about through our primary care advisory group. This is just one example of sort of trying to quantify those administrative burdens. It's from the American Medical Association, which conducted a national survey of physicians on the impact of prior authorization. So some of the numbers shown here, and there's a link at the bottom of the slide to the full data, but on average it's reported. Oh, sorry, was there a question?
Nope, you're good.
Oh, okay. On average, it's reported from the survey 45 prior authorizations per physician per week, 14 hours per week of physician and or staff time spent on the paperwork related to prior authorizations, and 35% of the physicians surveyed have devoted staff specifically for completing prior authorizations. And this all culminates in 88% of physicians surveyed describing prior authorizations as a high burden. And of course, on the patient side, there are a number of surveys done by different patient groups across the country about the impact of prior authorization on access to care. But to continue with the American Medical Association survey, this shows physicians reporting about the impact of prior authorization on access to care for their patients. 14% said prior authorization always delays access to care, and 42% says prior authorization often delays access to care. So across these three perspectives, we can sort of see the balancing of cost containment and the need for making sure that care is medically necessary as we talk about healthcare costs. But on the clinician and patient side, challenges related to the administrative burden and access to care. So that brings us to a discussion of what are the existing laws and rules for prior authorization in Vermont. And I'm going to let Sebastian take it over for a bit.
Great, thanks.
Okay, so I'm going to pull back a bit so I can see the slides. So at the first stage of the prior auth process, in Title 18, we limit which services insurers can require PA for, especially with respect to medication assisted treatment for substance use disorder. Then for things like imaging. We require health plans to review their PA requirements at least annually and eliminate those requirements that are no longer justified. And we're going to talk about this a little bit more later, but until now, this requirement was added in 2021, and for the last 2 years, we've required the insurers just to submit a very basic attestation that they are complying with this requirement, but we'd like to propose beefing up that attestation a bit, so you'll see that later.
And so can I just, when you keep saying we, you're talking about DFR specifically? Okay.
Then the DFR, along with other stakeholders, require a uniform prior authorization form for medical prior auths. So every payer still has its own form for pharmacy because for a lot of the reasons we had just talked about with PBMs, it is very difficult to have payers that all use different PBMs have the same prior auth form for pharmacy services. So for medical services, there's a uniform prior auth form that all of the payers use. And the department is currently working with DIVA, Blue Cross, MVP, and Cigna to update that form. We first did it in 2014 when 9418B was enacted. And we are in the middle of updating it now to give the payers more flexibility to give their members specific instructions insofar as what data might be needed or clinical information might be needed to support a given PA request. Then for the point of the process where the insurer is reviewing the request, the insurer has 48 hours to respond to an urgent request, and then 2 business days for non-urgent requests. And then if that request is denied for urgent matters, the member can request an internal grievance of that denial, and that's supposed to be resolved within 3 days. And then if that is denied, then the member has access to the external appeals process, where with the department's facilitation, we'll get all of the clinical information from the member and the insurer, and we'll send that off to an independent review organization. And they have each independent review organization that we contract with have thousands of providers across the country in any specialty you can imagine that will review the case and then either uphold or reverse the insurer's decision. And then, that is sort of at the last stage. So I jumped a little bit ahead of myself because I'm actually the person who manages our external appeals process. So I like talking about it.
Art and then Daisy.
Excuse me. When a physician orders a test of some kind, or orders a drug of some kind, I assume they do it blind to what the insurer might say.
Yes.
Okay, in other words, my doctor, my wife has just had an MRI. Okay, so she doesn't care what insurance covers. She's ordering the MRI because it needs medically to be done. It goes through the system. But insurers will use what policy you have to determine whether that's covered. Is that how?
Yeah, so prior authorizations are for services that are already covered. So for instance, a lot of advanced imaging like MRIs require prior auth. Those services are already covered. What the prior authorization is trying to do, like Julia was explaining, is for the insurer to make its own determination that the service is in fact medically necessary for the insured's condition.
It almost sounds like and I thought this as you were doing it, like a check on the doctor.
Yes.
It almost seems like it's a check on competency of the doc. I mean, I don't know, how many are turned down?
In a lot of ways, it almost is. And when I was meeting with Julia yesterday to discuss the presentation, I said that, well, if I had to go to the Department of Human Resources every time I wanted to do something or to justify me getting paid, like I would be a bit salty about that, no matter how justified DHR was in requiring that.
Right.
Right.
Yeah, and so what percentage are disapproved? Do we know that?
We do know that. Under Act 152 of 2016, every insurer is required to submit a report which includes the number of claims they received that required prior auth, and of those, the number that were denied in the first instance and then reversed at the first level appeal process or the second level appeal process or during external review. So this data is, we've compiled it for the last 4 years and it's on page 4 of the report. But for Blue Cross Blue Shield, it's typically 90% that are approved. And then for MVP, that's in the 20% range. Again, this is just a rough average of the PA denial rate. And then for Cigna, it's more on the order of 30%.
That are disapproved.
That are disapproved in the first instance.
Before appeals.
Before appeals, yeah.
Right.
Daisy?
So I'm curious about the prior auth forms, and I guess it's step 3 and the uniformity of them. What triggers the update that you referred to earlier?
We were approached by DVA who wanted to make some changes that were specific to Medicaid. And then separately, we were approached by Blue Cross that wanted to make unrelated changes. So it just occurred to the department that since the statute requires a public process, including a public hearing to change the uniform prior auth form, that if there was this much buy-in from major stakeholders, that justified opening up this process and trying to make as many changes to the form as we could while the stakeholders were interested.
But there's nothing in statute that has a standard
That's right.
review process for updates. And then can you speak to any issues with regard to the updates and interoperability? Is there any issue with that?
The updates in terms of the federal interoperability.
Yeah.
So the update on the federal interoperability standards is that back in December of 2022, CMS proposed rules that would require the payers to basically develop and maintain an API for transferring data that would be interoperable. So the history of this is that Congress asked CMS originally to come up with a data interoperability standard. CMS tried. Neither the provider community nor the payers liked what CMS came up with. And then what essentially happened is that CMS threw up its hands and said, all right, you do it. So that is where we are on the long march to a federally imposed interoperability standard. It's the kind of thing that no matter what is eventually decided upon, it will be painful for one group or another that will have to change their IT infrastructure to comply with that standard. But it's the kind of thing where once that pain has been dealt with, it will be easier for everybody.
And I'm especially interested in that because of the cost of it.
Yes.
So if they are not imposing the specific model of what that looks like and letting us figure it out, does that then push the cost of implementation to us, or will we be able to tap into federal funds for that?
Yeah, I can't speak to the availability of federal funds, and unfortunately, they're still very much at the planning stages. But if I had to speculate, I would speculate that especially for the provider community, there would be federal funds available to come into compliance with whatever interoperability standard is eventually decided upon.
Okay, we're gonna do Topper and Mari, and I'm gonna ask everyone else to hold their questions because we have to keep going. Topper.
An urgent request. Is there a definition of that someplace?
Yeah, so the statute doesn't define urgent. So it's typically used for like your standard like emergent services, like someone needs emergency surgery, emergency imaging, but this is something that this is an issue that has been raised to the department by the payers, that they would like more guidance on like what constitutes an urgent request.
Mari?
Other than the appeals process, does DFR have the capacity to evaluate, maybe from the information they get from the reports, the validity of denials, and what the motivating factor was? For example, MRIs are really expensive, so maybe the insurance company is saying, we don't think an MRI is necessary, they should have a CAT scan, which is a clinical problem. So is it possible for DFR with the information that you receive to objectively suss out the rationale behind denials?
So that's a good question. With respect to the appeals that rise to the level of external review, I think we've found that the payers in all cases have valid reasons for the denial, and it certainly did not objectively seem to me like they were making things up. On the other hand, in situations where, let's say, a payer was denying all claims in the first instance and requiring members to appeal, that is something that would potentially draw our attention to exercising some of the authority we have under the statute.
In the first instance, you mentioned the validity that DFR found in the denial was based on clinical information.
Yeah, and that's in the external appeals process. We get the insurer's denial letter plus all of the clinical information related to the claim for both sides. So I'm not a provider. I don't have any medical training, but there's enough there for me to see, and I think for the reviewers to see that even if a denial is overturned, that the insurer had a point in terms of reliance on studies or what the clinical notes may have said.
You have a clarifying question?
Well, only because it's the data that Julia just put up, that how many of the appeals were overturned in the first, second, and final. Like if you, that sheet that she just had up, it's on your slide showing.
Okay, so let's wait till we get, let's
Yeah.
pull that question.
Yeah, it's kind of
We'll
goes
get
with like if it were, they were, so maybe we can, when we get to,
Yeah.
if they're overturned and why, if they're.
Right. Okay. Let's keep going with.
Okay. So we've there's been a long history of work on prior authorization in Vermont, and for the purposes of this presentation, we're only going to go back to 2018. So for that, I'll turn it over to Julia.
Yeah, and I've briefly put up this bigger chart. We're not going to walk through it, but we just, for your reference, wanted to show you and kind of catalog the further work that has been done in terms of pilot programs and the board's primary care advisory group, which I will talk about in a little more detail, and then we'll kind of catch up to present. And then we'll get back to sort of what some recommendations we've made for the future, which I know is where we're all kind of eager to jump to in terms of the conversation. But on this slide, I have some recommendations that the primary care advisory group, which is convened by the Green Mountain Care Board, put together in 2018. And the themes, as you can see here, is that their recommendations are related to eliminating or streamlining prior authorization, specifically for primary care, because of the sort of challenges associated with changing requirements and the administrative burden, and all of the things we've already discussed. And this has been a continued theme that the board has heard about over the years from the primary care advisory group. And I know it was just shared with the chair, but last week, the Green Mountain Care Board had a roundtable about the sustainability of primary care. And while, as you can imagine, a lot of the discussion was about finances and workforce and a lot of other challenges facing primary care, prior authorization came up throughout the multi-hour discussion, as well as in the primary care advisory group meeting that followed. As a big sort of burden to the well-being, or kind of like contributing to burnout of primary care providers as it relates to the paperwork and administrative burden, and like was brought up earlier, kind of the needing to check any recommendation that they're making for their patient in the form of this paperwork. So moving to a little more recently, I have a chart here about the gold carding reports. These reports were submitted to the Green Mountain Care Board as well as your committee in January. I want to be clear that this is just a short attempt at summarizing. It is not exhaustive by any means, and I definitely recommend you take a look at the reports. They're a couple pages from each carrier, but as a reminder, gold carding is a program that essentially would exempt a clinician from a prior authorization requirement for a particular service or medication based on that clinician's track record of approvals. So to make that a little more concrete, if a clinician has, say, over a 90% approval rating of prior auths for MRIs, then a gold carding type program would say that they would not have to request prior authorizations for MRIs for that specific insurance program. So it follows the provider and is related to which payer we're talking about. So kind of the continued theme of that overlapping groups. But the main takeaway of this chart is that the 4 carriers here started pilot programs for gold carding. They were specific to either imaging, and in one case, a pharmaceutical example. The main takeaway that I thought was important from these reports is that 3 of the 4 carriers plan to continue these pilot programs. And the one that didn't have any providers qualify in the first place. So I think at a high level, it's a promising result for these types of programs. And as was mentioned earlier, H220 includes a section on prior authorization, which would essentially expand this gold carding style program. So I will hand it back to Sebastian to talk about some of the other work that's been done on prior auth.
Go ahead, Barb.
Yes, Julia, could you put that slide back up?
Yes.
This is already underway now, Julia.
Yep.
This is from 2018.
2020.
2020. Oh, okay. I'm sorry. Yeah, I see it now. Okay.
And important to note, of course. Oh, sorry.
So this is on the path toward eliminating it altogether. Is that kind of what this is a step in that process?
This is a pilot program for giving providers, having them not need prior authorizations for very limited services. So each program was different, but we're talking about 1 or 2 services, not all together in these pilots.
Okay. But you don't have to go back to it. The previous slides, and one of the 2018 recommendations was do away with it altogether.
Yep. So that's what the primary care advisory group, which is a group of primary care providers convened by the board, that's their recommendation. This has not been done, but this is what they have advocated for because of the burden that they have felt from prior authorization.
Was that ever bandied about and considered? Or?
Yes, it was in this committee. It was in this committee, and that's what led us to the gold carding in 2020.
Gotcha.
Yeah.
All right. Thank you.
Because as you can imagine, the insurers, which I understand why, they came in pretty hard and said, we can't just eliminate. And so doing this gold carding was a compromise to start us looking at what's really happening and why it's important for us to continue looking at it and potentially expand it.
Right.
Yeah.
Okay. Yeah.
It's special.
Okay. So could you... Okay, so the main reporting that we receive on prior auths is, as I mentioned earlier, collected under Act 152, and it provides aggregate information about the number of PAs by category, the denial rates, and then what percentage of those claims that are denied then go on to be overturned at subsequent levels of review. And although it's helpful to understand the overall landscape of prior authorization, it's not specifically connected to any regulatory process that the department undertakes. So there's no requirement in law that a certain percentage of PA claims have to be denied in order for that PA to be justified. There's nothing like that. So the next slide is a snippet from one of our reports, and I might ask Julia to zoom in a little bit so you can see the numbers. Thanks.
This is the slide I was talking about.
That's better.
Okay. So this is an example from Blue Cross Blue Shield of Vermont's reporting for 2021. We break it down into 3 categories: medical, which is your imaging, medical procedures, mental health and substance abuse, and pharmacy. So for 2021, there were a grand total of about 32,000 claims that required prior auth, with most of those being medical prior auths. For medical services, 7.2% of those were denied in the first instance. Then for mental health substance abuse, it was 3.8%. And then for pharmacy, it was 27.5%. So overall, 14.6% of PA claims were denied in the first instance. So that's how you read this part. Then continuing on this table, but what we see is that most PAs that are appealed to the first level are pharmacy claims. So out of those 27.5% of pharmacy claims that were denied, 157 or 1.3% of those were appealed. And then at the first level, I'm just going to continue down with pharmacy because that has the most claims. 108 of those were overturned. And then of the 7 that were then appealed to second level, 5 were overturned at second level review, and then only 1 made it to external review. And then that was overturned.
So Melanie, okay, hold
So
on.
that was the
Melanie.
question that I was kind of piggybacking on Mari's question is like, just wondering why was it appealed for clinical reasons? Or was it overturned for clinical reasons?
Yes.
Or was it like clerical or miscoding?
Yes, so any claim that makes it to external review, it will be overturned for medical reasons, because the only bases for external review are that the insurer denied the claim because they judged that it was not medically necessary, or that they judged that the services at issue were experimental or investigational. So
Is that true for the other phases too?
no, at the other phases, those can be overturned within the insurance company because it was a clerical error, or there was some other bureaucratic issue. But because of how the external appeals process works, remember, we are sending the matter out to another clinician for review. They are only looking at the medical issues that are raised by that claim.
Leslie Mari Olson.
I'm just trying to understand sort of the length of time that goes through this process, like from when you start at
Yep.
2 to get down to step 15. Sorry about my. How long does that take? And if I'm understanding this right, it looks like a quarter of total PAs denied. Can you tell me what that's 11, almost 12,000. What does PA types mean?
Oh, so we can
And I'm looking at pharmacy.
go back to like right here.
Yeah.
Oh, so that's the count of prior authorization within that type of service. So
A quarter of the PA of those prescriptions were denied? Is that what I'm understanding?
yes, so at the first level, a quarter of PAs were denied.
Okay.
It sounds like a lot,
Yeah.
but from a regulatory perspective, it's kind of what we want to see. Because if an insurer or payer is imposing a prior authorization, we generally want them to have a good reason to do so. And if they're denying the prior auth, like 25% of the time, that suggests that the PA is not entirely unwarranted.
Wait, that's a double negative. Oh, it's
Sorry.
Yes.
Sorry. If they are, so if an insurer has a PA requirement and they are approving this PA 95% of the time, well, that's great for the patient, but then why even have the PA?
That's sort of what I'm struggling with, because then you go down to 157 that are appealed.
Yep.
And what happens between in 1/4 down to, like 1%?
Yeah. So what happens is that most patients who have a prior auth denied do not appeal it further.
So what happens to their medication? They just accept that the insurance company is in charge of their care rather than their clinician?
Or they'll, like we were discussing earlier, in a lot of instances, there are different therapeutic equivalents. So perhaps the patient wanted, or their provider prescribed drug A, but drug A requires a prior auth and drug B does not. So it's sometimes the case that they're not able to get the medication they wanted or were prescribed, but there 99% of the time there is a therapeutic equivalent that is available to that member.
So we're gonna, go to Alyssa first, and then we're coming back to you because she's connected to this.
Yeah, just slightly connected, because I'm wondering if in those 12,000 PAs, if it's broken down by drug class.
No.
Because I do know that you will oftentimes prescribe a medication that you know is not covered. The patient still wants it, and they are willing to pay out of pocket. But the prior authorization comes in when they try to go fill it at their pharmacy, and you do the prior authorization to get the denial, knowing full well that's going to get denied. And I'm going with erectile dysfunction drugs, because that's a big one. So I'm wondering if it's broken down, because that would be really helpful. I mean, that number is staggering, 27%.
Yeah.
But the reason I think most don't get appealed is because they knew they were never going to get covered in the first place. And you're just looking for the denial.
Yeah,
so they can buy out of pocket.
That is a viable theory, but we don't break down the denials by drug class.
Okay.
Mari, and then Art, and then we're gonna keep going because I want to get to the recommendations.
I read those.
So mine is also related and
Sorry.
staggered by the 27.5%, knowing, as we know, that pharmaceutical costs are the biggest drivers of the increase in health insurance costs. That I'm suspecting that 27.5% also has something to do with PBMs controlling the formularies, and that providers ordering medications that they think that their patients should have are being denied because the PBM said that, well, your insurance can only cover these medications. So it would be interesting to be able to go into more detail in the data around that 27.5%.
We can also hear from, and we will hear from providers and others. There's a million sides to every story on this one. So
Is that something that you can respond to?
I agree that it would be interesting, and I wish I could. I wish I could share that. It's not a thing that's reported under X122.
Art?
Yeah, just a quick question. When they deny any of these things, do they recommend another course of action on the denial?
Yeah,
Or
so.
do they just say no, you know?
Yes, so in our regulations in Regulation H 2009-03, there are there's a whole laundry list of information that an insurer has to provide a member when they deny prior auth, including what their internal and external appeal regs are, and what the options are moving forward. That's why if you ever have a claim that is denied, you'll receive a packet of information that's like 15 pages long.
Which is so confusing.
So that doesn't
That's
go.
part of the issue.
It would go to the provider too, or to the?
It goes to
patient?
the patient.
It goes to the patient.
Yeah.
Hasn't been.
But the provider will also know that there's a prior auth that's
It
been
didn't
denied.
apply,
Yeah.
okay, all right.
All right, let's keep going.
And if I could just add one
Sure.
point quick, I think some of the questions that we were hearing before about kind of going back to the 27% and some of those examples, I think it's also, let me fix my Zoom a bit. It's also helpful to remember, I'm just gonna show our little diagram again quick, that as it relates to this step, everything Sebastian was talking about is in this last box. Like everything in that chart you just saw is related to once the insurer has made a determination, but there's also a lot of up and back that can happen in this third box, between the third and fourth box here of submitting the paperwork. The insurer can respond and say, we need more information to properly evaluate this request. So even before we're at the point of having a denial and needing to appeal it, which is what the data we were just looking at, there's a lot that can happen as it relates to requesting further clinical information. And I think some of the questions that were just coming up maybe are also like a lot is happening in this step. So it's just sort of important to remember that there's many places where further information can be shared on this subject.
Thanks, Julia.
Oh,
So, that is a good segue to the meat of this report, going back to that third step where the clinician, the provider, needs to share clinical information with the insurer to support a prior auth request. So one of the items you asked us to look at in this report was the viability of using the Vermont Health Information Exchange, or VHIE, to support prior auth requests. And in theory, it's the kind of thing that should work because the VHIE is meant for providers to share clinical information about their patients with each other. So if you're a PCP and you refer one of your patients to a specialist, you don't have to like fax over their whole medical record to the specialist. The specialist can just pull that data from the VHIE and then continue their work. In theory, it should work the same for an insurer that needs clinical information to support a prior auth request, that the insurer could just go into the VHIE, find the patient's clinical information, and then use that to either approve or deny the prior auth request without any further action by the provider. There's no like back and forth trying to fax or electronically submit records. Unfortunately, as with all things healthcare, it's a bit more complicated than that. So the big issue with the use of VHIE to support prior auth requests is that it only supports a limited number of data types. So admissions, discharge, and transfer messages are in there. Immunization messages, continuity of care documents, and lab reports, which is great for providers, but for insurers, they need the clinicians' clinical notes, which are often either not in the VHIE, or if they are, they're not consistently reported. And I think this is an issue that you've all heard from providers trying to use it for medical purposes.
I'm just curious, whose responsibility is to get clinical data from the clinician's office into VHIE?
It is the provider that does that.
So someone in your office is doing that? I think so. I mean, yeah, so there seems to be a gap.
So let's hold that question.
Yeah, I'm just wondering about, I mean, if it's not happening, then it's not happening.
Yeah, I mean, that's, I think, part of the whole issue.
Problem.
Over the summer, Blue Cross Blue Shield of Vermont actually did try to do this, and in conjunction with Vital, Vermont Information Technology Leaders, which administers the VHIE, they tried to process 231 prior auth requests just using information in the VHIE. And at a high level, it is feasible. They were actually able to approve prior auths using VHIE data, but in a large number of cases, they were not able to do so, and largely because of that issue with, like, okay, well, the members' labs are in VHIE, but not the clinical notes that support the necessity of the service. And then another issue with it from the insurer perspective is that under the terms of use for the data, they can't use it to deny prior auth claims. They can only use it to approve prior auth claims. So if there's any additional information the insurer needs, or if the information in Vital is alone enough to deny a request, they still have to go back to the provider. So it doesn't ease any of that back and forth between the insurer and provider. We go into this in more detail in the report, but as a proof of concept, it does work. It would just be, there are a lot of issues with the consistency of reporting that need to be addressed before it can be scaled up.
Leslie?
So I'm wondering about the electronic medical record that I think there are many platforms across the state. Is there interaction between those and this platform? Could it be just like moved over that way, or could we think about it from the EMR point of view, or?
I think that's a good way to think about it. And I would just defer any questions as to the technical aspects of making that happen to Vital.
Thank you.
Okay. Did you have something?
Oh, just thinking.
Okay, go ahead.
One thing that I did want to note that that Blue Cross told us when we were discussing the pilot and how it went was that having access to the VHIE data was actually great for their case management teams. So for patients who have a lot of needs, insurers will sometimes assign them case managers to help them find the appropriate care and connect them with in-network providers and things like that. And because these teams typically only work with claims data, their visibility into the member's condition can often be a little limited. So they thought it was great to have access to the more clinical kind of data that's in the VHIE, and it helped them get those members access to services. So that's the kind of thing that can, the kinds of synergies that can be achieved by trying to integrate data sources like this into the prior authorization framework.
That's helpful. Thank you.
Cool. So the Julia, can we skip to slide 21? So just to close out our discussion on the utility of VHIE to support prior auth requests, I think the report urges that insurers be able to use the database to both approve and deny prior auth requests. And then, like we were discussing, providing training, incentives, other pathways to increase the amount and consistency of the data that's in the database. And thirdly, to secure a funding stream for it that is not dependent on user fees to operate. So that brings us to the next part of our report, which was to identify alignment opportunities for prior authorization. And in doing this, we tried to look at what other states and the federal government have done to require insurers to submit all of their services that required prior auth and what the clinical requirements to approve those requests were. And we found that while many states require insurers to put their prior auth requirements on their websites in some way, no state nor the federal government requires reporting all services that require prior auth and what the requirements to meet that prior auth are. So we then reached out to UVMMC to try and get a handle on if we were going to require insurers to report this, what would you like to see? So they sent us a spreadsheet template, and when it in just template form, it looked really great. And we were like maybe this is doable. And then we showed it to the payers, and their response was like, yes, this is doable, but you'd have a spreadsheet that has like 150,000 entries, and it would take us a lot of time to produce. It would be impossible for you to interpret, or you could. You just need years to do it, and and also our prior auth requirements change year over year. So you'd effectively have like a one-time snapshot of where we are with prior auth requirements. And by the time you had compiled all of that and organized it, it would be outdated. So we thought there wasn't a lot of utility in requiring that submission, and instead wanted to look at other levers we had to get to the goals that you set out in the legislation. And one thing that we are going to starting this summer for the next round of reporting about the attestation is requiring insurers to not only attest that they've reviewed their prior auth requirements and are removing prior auths that they feel are no longer necessary, but we're going to ask that insurers provide us with a general description of the standard they use to evaluate their PA requirements, list all services for which prior auths were either added or eliminated during the prior plan year, and the rationale for changing that requirement. So if an insurer added a prior auth for a new medication, we would ask that they explain why does this medication require a prior auth? Then we would ask for a list of the 10 most requested services that require prior auth and the approval rate for those services, and the percentage of prior auth requests that were granted because the processing time exceeds the statutory timeframe under 18 VSA section 9418. So just to back up, remember how we talked about how a prior auth has to be processed in a certain amount of time. If it's not, then the law deems that prior auth request to be automatically granted. So we want to get a sense of how often that is happening.
Stop there for a second.
Yeah.
Alyssa, and then I have a couple questions.
I don't really have a question. I really wanted to make a comment though.
Okay, sure.
Well, you put up that slide and you were talking about how the insurance companies were like, oh, this is ridiculous, we can't do that. And everybody's laughing about it. That is what providers have to do every single day. Trying to navigate and figure out what needs prior auth, what doesn't. So you know what they end up doing? They do prior auth on absolutely everything. Multiply it not just by every procedure that you were, multiply it by every different insurance company that has different criteria. Try getting a prior authorization when you don't know what the requirements are to get that prior authorization, and multiply that by every different insurance company because they're all different. I just want to make that point. And I just want to go back to the fact that on this very first slide, clinicians order MRI for patient. A licensed clinician, an educated clinician who knows best practices. And all of this because an insurance company wants to go back to, we want to check to make sure that you're doing things the way we want you to do them. And I'm sorry, I mean, this is a big issue and this is an important issue. And I want us to remember why we're even thinking about something like this.
Can I expand on that just for 1 second? 1 second.
Can I,
Sorry.
I was gonna say first.
Oh, sure.
Let me say first.
Emotional.
No, and I just want to be clear, when she says insurance companies, we're not just talking Blue Cross Blue Shield and MVP, right? So every person who has a employee-sponsored health plan, you know, so it's not just those two and Medicaid.
Right,
It
right.
could be hundreds that they're dealing with.
And I want to add one thing also. Not once has an insurance company been able to come in here and tell us how much money they're saving
Right.
from this process.
Question.
They've never been able to tell us what they're saving.
Could I add to that? As a clinician who has lived this, I am I have to call a doc, you know, from the insurance company in order to do the appeal when they reject it. They have never seen the patient. They have no idea who the person is in front of the ordering clinician. So the case has to be made by someone who has seen the patient, who understands what's going on with them, to someone who has no idea and whose only object is to save money. So it's a really strange, one of my questions was, well, why did it get started? But that ship has sailed, clearly. But I really think it's unjust. So I'm just going to say that. Thanks.
Sebastian, when is this reporting due? So this next report where you're going to require these things, when is that?
So the attestations under 9418 are due in June.
Okay. So you'll be able to have some of this data in this coming June?
Yes.
Okay. And then my other question is, and it goes back, I wrote it down like as soon as you started. What, if any, statutory requirements or authority does DFR have to set up a process for how and when PAs can change? Is there a process today first, and then, you know, is there a process, and then is there a public notice process?
So the department does not have any authority to approve or deny an insurer's request to, say, add a prior authorization requirement or to regulate what an insurer can require to meet that prior auth requirement. Like we said in our report last year, we do have, I guess a good term would be rails on either side that govern the prior auth process under Title 18, but insurers have a lot of discretion to remove, add, or amend their PA requirements as long as they are staying within those rails.
And then my last question before we get, because I know the next part is about legislative action. What on that, sorry, Julia, if you can go back to that last slide real quick. What is your and both of yours organizations' goal in getting this type of reporting? What do you think could come out of it?
I think from the department's perspective, our goal in getting this kind of reporting is to ensure that the insurers are indeed following what the law requires them to do in terms of actually looking at their prior auth requirements and removing any that are unnecessary. And we feel like by beefing up the attestation, we'll have more insight into the process that they're using, more than just a bare, like, yes, we are complying with the statute.
Okay. Julie, I don't know if you had anything to add from Green Mountain Care Board's perspective.
Yeah, no, I appreciate it. Hard to jump in when you're not in the room. I think you covered a lot of good stuff. I did just want to respond to what Representative Black and Goldman brought up about sort of the frustrations around the process. And, you know, the board worked with DFR when they were looking through sort of that template that they received from UVM and thinking about like what are the best options for data collection. And like I've said, we hear every time we meet with the primary care advisory group about the challenges and frustrations and like time spent on the phone waiting for a clinician who hasn't seen your patient to talk to you about these issues. So I know it's easy to kind of be laughing about the volume of information because it is just like you can't visualize how much information there is here, but we do. I just want to reiterate, like we really understand that volume information is a burden on providers, and so we are hopeful that receiving this information will provide valuable insights to your committee in future years. And as we transition into talking about some of these opportunities for legislative action, that maybe knowing some of these, frequent prior authorization scenarios and the rate of those approvals might provide some helpful information as you consider some of these legislative actions that you may take in the future. I'll treat that as a segue as well.
Yeah, we have a segue, but one question before we segue. Tucker.
I think you might have answered my question, but does clinician mean MD?
I believe it's broader, but that would probably be a question for the insurers about who they, whether it's in-house or who they contract with to look at their prior authorizations.
Okay.
Sometimes it's a
Nurse practitioner, PA.
Let's put that on the list.
But it's probably different for different insurers.
Okay, legislative action.
Okay. So just to preface, just bear in mind that we can't, this is old hat for all of you, but the department only has jurisdiction over fully insured health plans. So we're talking about the sliver of the market that is represented by qualified health plans and fully insured large group health plans.
Thank you for that reminder.
We also have authority over our state Medicaid program, and they have their own prior auth requirements.
Okay.
So can we skip to slide 26? Great. You want to start, Julia?
I am happy to, although I think you might be able to tick off your couple more quickly, noting that we have 15 minutes, and then I'll see what we have time for at the end, if that works for you.
Okay. So the opportunities for legislative action that I wanted to discuss happen right here, which is I think there are opportunities to improve the quality and quantity of clinical data in the HIE. I know this is a larger issue that you all have addressed, but it would not only go to help providers exchange information with each other. If the data set were more robust, there would be more opportunities to use this in the context of prior authorization, and then there would be less of this like waiting for the federal interoperability standard. So that is an opportunity for improvement. The other potential opportunity that we have is we could consider adding to the guardrails around PA by prohibiting insurers from requiring reauthorization during the current plan year. So there are a lot of services, particularly with respect to pharmacy, where the patient gets a prior auth, but that prior auth is only good for 6 months, let's say. And then they have to get reauthorized. This is sometimes called concurrent review. I think there are opportunities to limit the number of services for which insurers require concurrent review, seeing as how they approved the services within that plan year. And then finally, we could consider amending 9418 to decrease the timeframe for health insurers to respond to completed PA requests for urgent services to 24 hours, which is required by about 10 states right now. And this is something that I think should be done in conjunction with refining the definition of urgent services. But for the people who need a service done now, 48 hours is too long to wait, and moving down to 24 hours would bring us in line with a number of other states on this issue.
Okay, great. Any questions on that?
Did you say you would have clinicians come and talk about this?
Yes, it may not be this year, but yes, we will.
Because back pain's a really great example of how this is a really difficult prior auth, and I'm happy to talk about it if you thought it would be helpful someday.
Okay. All right, Julia.
Yeah, I will take a couple of the meatier ones. So gold carding, we already or actually stepping back for a moment, the two that I'm going to talk about both have to do with whether a prior authorization is required in the first place and in what scenarios it's required. So they both have to do with that second box on this image. Gold carding, as we covered previously, would create a scenario where a provider does not have to request a prior authorization for a certain service that they previously have a high approval rating on. And again, that would be in the context of a particular insurer program. That proposal is laid out in length in H220, which was introduced by Representative Black. I know there's a lot of details there, so I think I imagine the committee will have further discussion on that front, but I can say at a high level, the board supports this type of program. We've seen over the years with the pilots that, some positive outcomes from it. And again, we continue to hear about the challenges that providers are facing. But in terms of the details, we haven't had a chance to dig into it. And I know the committee will be doing that in the future. So we look forward to that discussion. The other one I want to talk about is called step therapy, and it piggybacks well on the conversation that this committee had earlier this morning related to pharmaceuticals. But also possibly confusingly. So we'll see how I do on this. But so I'm going to go to this last slide. So a number of states have taken action on this topic called step therapy. Step therapy is a subset of prior authorization where an insurer says, before we will cover drug A, which is the drug that your provider has prescribed you, we require you to try drug B to see. We would prefer that you take drug B or maybe drug C. There could be multiple steps, they're called, where a patient has to try and show failure on that medication. Of course, failure means that it's not working, that the patient's condition is not improving, which is, of course, a challenge for the individual's health. So what other states have done as it relates to step therapy is to say that in certain scenarios, a patient can bypass the required steps. And before I describe those, I just want to be clear again that this all is about medications that are already covered. I know we talked about formularies as medications that an insurer is covering as part of the plan. So in my example, drug A and B are both covered by the plan. There's just a preference by the insurer through the step therapy process. So what some other states have done is to say that, for example, if the medication that the insurer is requiring has been known to be ineffective for the patient, they could skip the step. For example, if I already took the drug last year on the same health plan and, you know, the plan year starts over and they say, we want you to go back and try this other medication first, you know, this would create a pathway to more quickly say the patient's already tried the medication, they should skip this step. That I think is the most straightforward example in this list. The other things that, again, that Massachusetts and other states have done are to say if the patient has tried a drug in the same pharmacological class. So that's getting at the questions that were coming up before about medications in the same class, which I'm not a pharmacist, but which can, you know, kind of work in the same way. So saying if you tried something similar, you shouldn't have to try something else similar before you can advance to what your physician or clinician has prescribed to you. And finally, if the patient is already stable on a medication. So again, I think a good example is if the plan year resets, you know, if you started taking a medication last year, or maybe you've been taking it for a decade and all of a sudden your health plan prefers that you take a different medication first, it would of course be really disruptive to the patient's health to potentially switch medications. There can be long kind of ramp up periods or ramp down between some of the more complicated medications. So these are examples of what other states have done specific to this step therapy, which is a pharmacy specific version of prior authorization. And additionally, the Massachusetts bill also requires insurers to report about the number and type of step therapy exception requests that were received and approved. So while they put these laws in place, they're also requiring ongoing reporting about how it's going so they can monitor. So this is one very specific example of action that's been taken in other states. So that is the end of what I was covering. I'll go back to the general slide so we can all see the whole picture.
Thank you. I think Jeff wants to say something.
Yeah, for the record, Jeff Hockler. I'm going to put my National Community Pharmacy Association Legislative Committee hat on for a second. What Sebastian stated about the old hats, about what they have in their scope of jurisdiction, that is not wholly accurate. There are active legal battles happening across the country. Oklahoma Insurance Commissioner in particular already. His case is testing the limits to which the Arkansas SCOTUS ruling allowing or defining where the ERISA preemption line is drawn. He's testing the waters on that actively. But to say that the Department of Financial Regulation does not have authority over self-funded plans when those plans in fact underpin the rate filings and rate setting for the commercial book of business, that's inaccurate. So
it's accurate for this moment in time. Yes.
So I would say that it's being actively litigated right now.
Right. And we hope that they win and then we can do some stuff on our side too. But for now, we have what we have in front of us. So this was excellent. Thank you both very much. Very clearly laid out. Again, another excellent report. This will be a priority. I'm really kicking myself that we didn't take this up earlier this year, but this will be a priority in January from my standpoint. Would love to hear what everyone else thinks at some point, but not right now.
I'm not gonna think. I just want to know, is this attached to a bill or we'll start a new bill?
No, there's H220 is on the wall.
I'm looking at that, yeah. Is that the bill to look at?
That is the bill to look at for some of the items, yes.
Correct.
Yes.
Thank you.
So we're done, and we will be back here 15 minutes after the floor for S47, and hopefully get a lot of our questions answered through Katie McGlynn, Legislative Counsel, walking us through the process. Not necessarily